why this is necessary, and I think even Jose is a believer now. And so to start this off, I'm going to segue from what John talked about. So everybody who's a physician in the room, raise their hand. And of the physicians who in the room, keep your hands up. Everybody keep your hands up. How many of you are doing the same thing you were doing when you left residency? Absolutely zero. So now everybody's non-physician, raise their hands. And how many, oh, there's, you gotta have more non-physicians than that. How many of the non-physicians in the room are doing exactly what they were trained to do as an undergraduate? None. So nobody, not a single person in this room. Oh, one, only one. And I think that's the problem, is we're stuck in this traditional American Board of Medical Subspecialties paradigm that governs sort of medical practice in the US. There's 24 member boards, 40 specialty certificates under those boards, and 88 subspecialty certificates. And there have been no new boards added since 1991 with medical genetics. And you know, while this siloed model may work for training, it doesn't accommodate changes in medical practice or optimally meet a patient's healthcare needs. So, Nick, how did you end up in vein disease? You're not doing what you were trained to do.
Well, I did stripping.
So how did you get to being a vein doctor? Why aren't you fixing hernias and gallbladders?
I wanted a better lifestyle.
So was that a decision right out of residency, or how long did it?
21 years later.
21 years. And you wasted all of that general surgery training.
You know, it could be argued. Yeah.
And Zoe, how did you get to being a vein doctor?
I was a bariatric surgeon for 10 years and then started treating my bariatric surgery patients' veins, and then just transitioned after the first 10 years strictly in veins.
And how many vein strippings did you do as a general surgery resident? A lot.
A lot, yeah.
And Dean's our non-physician representative. Dean's a textile engineer, which I think is a chemical engineer.
I am a chemical engineer.
You're a chemical engineer.
Correct.
And then this has nothing to do with
chemical engineering.
There's a lot of brain power that is gone to waste here.
Thank you.
Yes. So how did you, why are you not a chemical engineer today?
Yeah, just, you know, life changes, job opportunities, things move, interests change over time. In this role now is my third career. All of them kind of tie together, but no, I don't. The only thing out of my engineering degree I used that I learned was how to solve a problem. That methodology is still there, but, you know, building bridges or chemical reactors, distillation columns, couldn't do any of that.
I can hardly even pronounce any of those. but I don't think anybody would argue that Nick or Zoe or Dean don't do an excellent job at what they're doing. So why is medicine probably the only field that is governed by this paradigm where you're stuck in this specialty that you finish your training with, and you have no option that's recognized by the American Board of Surgery, or American Board of Medical Specialties, to evolve and change. And in particular, if you look at Zoe, how many ablations did you do during your general surgery residency? 0. How many strippings did you do? Too many to count. Well, technology has changed. And you know, this paradigm doesn't allow for adaptation over time with that. So if you look at superficial vein care in the United States, the bulk of it, and it's sort of consistent with our membership, 28% of it is done by vascular surgery, but a substantial amount by cardiology and general surgery, almost equivalent to vascular surgery. And I'm a vascular surgeon, but you have to ask why vascular surgery wants to build this fence around venous disease that's claimed their territory, and that's historical that we'll talk about. But you look, about a quarter of superficial vein care is done, and most of it very well, by people who weren't primarily trained in a surgical or cardiology subspecialty. A quarter of the patients are getting their care outside of these traditional groups, and that's exactly who our membership is. And you look at the training in venous disease, you really look at this, and this will be interesting to see what happens, because we've lit a fire a little bit, I think, with the American Board of Vascular Surgery. If you look at The requirements for vascular surgery, you have to do 20 endovascular aneurysms, 30 abdominal cases. There's not a requirement to do a single vein case during your residency. And I brought this up at several meetings, and I will bet you in the next 5 years, just to put a fence around the territory, venous disease starts appearing on this. And this is going to be very controversial because most training programs in the US don't have strong vein training programs. And are the aneurysm surgeons really going to want their fellow to go do a vein ablation rather than help them with the aneurysm? I bet the answer is no, but I bet they try to push vein cases in on this just to prevent any subspecialty from happening in venous disease, but it's going to meet a lot of resistance from vascular surgery. You don't want their fellows running off and doing anything but aneurysms, but we'll see what happens. And if you look at what the actual resident experience is, it's pretty dismal. The average, I can't see these numbers very well, the average vascular surgery fellow does about 4 operations for varicose veins. They do 1.4 sclerotherapy procedures. How many people in this room don't do sclerotherapy who are physicians or vein specialists? Not one. Do you really think that this is the venous experts that finished their training with 1.4 sclerotherapy procedures? A little bit better for endovenous ablation, about 9 procedures. For angioplasty and stenting, about 2. And yet this is a group who's trying to build a fence around venous disease. And for venous malformations, 0.1. So this is pretty dismal. Look at interventional radiology, the other field that would at least like to have some input in venous disease. I made this slide about 5 years ago. All of these numbers at the bottom is venous stenting, to be determined. This was 5 years ago in preparation for the Sumner session at the AVF. I looked at it again. Same graph is up there. Not a thing has changed in 5 years. And I bet if we look 5 years from now, it's still going to be determined. So there really is no AVMS pathway for adequate medical training, despite the fact that in venous disease, despite the fact that that governs medical practice in the United States. So does board certification really matter? And I would submit that it probably does. This is probably one of the better studies out there because it's very unbiased, which was a systematic review of 13 studies looking at the relationship between board certification and outcomes. The majority of the studies that were included in this systematic review did show that board certification led to a positive outcome. 16 out of the 19 they looked at. 3 had a negative association, that's worse outcomes with certification, and 14, it really didn't make a difference. One of the ones that it did was orthopedic surgery, where they looked at board certified versus non-board certified orthopedic surgery, and there was really no difference in the outcomes for knee surgery with that. But in contrast, in vascular surgery, comparing it to non-board certified general surgeons, lower stroke rates, lower death rates from aneurysm surgery. So I think the bulk of the data suggests that there is some value to board certification as far as patient outcomes go. So that's the first problem, is this AVMS model that is outdated. And it's always going to talk about, even the AVMS recognizes that this is an outdated model. And when we talk about the need for a subspecialization and people doubt where this can occur, when the president of the American Board of Medical Subspecialties is able to say, this is an outdated model, we need to change, this is something that can happen, because even though the AVMS has immense power, they realize that this is not a paradigm that's useful going forward. Second problem is this imbalanced workforce, and this is the problem with trying to put fences around territory. If you look at the epidemiology in the United States, you can come up with different numbers, but this is at least one source. 250 million with chronic venous disease, 6 to 7 million with advanced venous disease, and 500 to 600,000 with venous ulceration. And then we look at the providers. This is the AVMS data from 2020. There's about 3,500 vascular surgeons, about 3,500 interventional radiologists, about 7,000 cardiologists. Is anybody who's I know Carl's here somewhere. How many cardiologists are in the room? A lot, which is, you know, I'm surprised at this number, 7,000. I thought there were many. It seems to me you can't throw a rock without hitting a cardiologist. There's really only 7,000 of them in the United States, which is surprising. But if you consider these traditional specialists, that's a total of about 14,000 providers. So if you assume, which is a wrong assumption, Not every patient with venous disease obviously needs treatment. But if you consider these 250 million people, that's 17,000 patients per year per provider if you restrict access to just these traditional providers. And that's presuming that the average vascular surgeon and the average cardiologist wants to do veins rather than aneurysms or coronary disease or anything else. So clearly, there's way too much disease to try to build fences around your territory with this. And even if you only considered advanced venous disease and every provider from one of these traditional specialties did venous disease, that would be 495 patients per provider per year. So obviously there's a hugely imbalanced workforce. And some of this, then we're going to talk about plasticity, is just the fundamental disruption that's happened in vein care, in the last 20 years. This was traditionally a surgical realm when we did high ligation and stripping, and we did open venous reconstructions, and we did Palma-Dale operations and Meissner operations and everything else, and all of that's been supplanted. Which has been a good thing because it's disrupted the surgical paradigm of taking care of venous disease, where we now have all of these other specialties who are in fact better than us as vascular surgeons is taking care of it. I don't think anybody would argue that the interventional radiologists' catheter skills are probably better than the average vascular surgeons. Well-trained dermatologists' sclerotherapy skills are probably way better than the vascular surgery fellow who did 1.4 during their fellowship. And the same for vascular medicine and cardiology. And it's sort of come together in this field where we brought the expertise of all of these different fields that was formerly just taken care of by surgery into this new thing of venous and lymphatic medicine. So this disruptive technology has actually, if anything, improved patient access to patient care by moving it from a field where most people, surgeons, didn't really want to do venous disease, to now we have this workforce that really does want to devote their time to doing venous disease. And I think Zoe's going to talk, because I got this concept from Zoe, and I have to thank her for it, this concept of plasticity, either within a specialty where different physicians in the same specialty do different things, or between specialties. And that's where we are with venous disease, where the scope of service of physicians in different specialties overlaps. And really, this has the benefit of expanding access to patient care. So plasticity is a good thing, both for patients in that there's more access, and it's also a good thing for physicians. Like we talked about, our goals changed during the course of our career, and what we finished up in fellowship is not probably what we're going to want to be doing when we're 50. If that was the case, is there a single person in the entire world who would go into hand surgery where they wanted to spend 15 hours in the middle of the night replanting fingers, or transplant surgery where at the age of 60, you're going to spend 6 hours in the middle of the night doing a liver transplant? People's goals change over time, and this needs to change. And I think this plasticity, this is very important to recognize. Why does the AVMS recognize only 88 subspecialties when the AMA recognizes almost 250 subspecialties where people are practicing and devoting their careers to specialties that are outside what the AVMS recognizes as a specialty? And is there a difference in quality of care? And I think this is really important, and we need to change the dialogue on this entirely. This is from Margaret Mann and the Improving Wisely project that looked at patients undergoing Medicare claims, a total of 102,000 patients. The mean number of ablations was 1.9 per patient. And the outliers were defined as greater than 3.4 per patient. And the results shows that there are a lot of different people providing venous care. About a third of it is provided by physicians who are doing more than 35 a year, but a lot of it is provided by physicians who really aren't doing that much. And vascular surgeons are less likely to be outliers, was the conclusion. But if you look at this, if you look at the outliers, number one, the numbers are very small. And number one, most of the outliers are in fact vascular surgeons. This outlying problem isn't confined to any specific group at all, but the numbers are very low. And what do you think the number of outliers is, Marlon? You know, probably.
Currently,
Yeah.
well, over half on the follow-up study normalized once they got the report. But the total number, it says 106 right there, Mark. But that's for Medicare beneficiaries. We don't know for commercial payers or Medicare Advantage.
Yeah. So what's an outlier?
Oh, hold on. That's arbitrary, isn't it?
It
The way
is.
it was defined here may not be the best way.
Yeah, so I
May not
have,
be the best way.
yes, Rob.
We also have to make the observation, as I've made before, that this reflects the current practice in the environment. This is not necessarily best practice. We don't have outcomes data showing that 1.9 ablations per patient is correct, too few, too many.
That's very true. And I had a slide on this that I took out, and I used myself as an example where you say the things I like skiing and motorcycles. I like maybe 3 people besides my wife and Kathy. And I like beer. So am I normal? Am I within 1 standard deviation of normal? Am I within 2 standard deviations of normal, or are they just too weird to classify? And that's sort of the problem when you look at this data. So this is sort of looking at it a little closer. We need to redefine this argument, because this argument right now is being defined by vascular surgery. And this is from Peter Lawrence's presidential address from 2016, where he shows the 4,000% increase in vein procedures over the last 10 years. And the focus of this presidential address was inappropriate care in venous disease. Now, I would submit to you that this is not because of inappropriate care. This is because of new technology and expanding access to patient care, having more physicians who are able to do it, and having better technology to be doing it with. And if you look at this, as I mentioned, overutilization is being defined by groups with a vested interest in building a fence around venous disease. But does this really reflect appropriate care rather than inappropriate care? And I think if you look at the numbers here, these are the three of the series that have looked at the number of outliers. If you define it as 1 standard deviation, it's about 20%. I would suggest that 1 standard deviation in no statistical study is an outlier. 2 standard deviations is the standard, and it's about 5% of physicians doing vein procedures are outliers. This is not an overutilization problem. If it was overutilization, you would see many more outliers in this. Most of this increase is by improved access to care, which is because of societies like the American Vein and Lymphatic Society, and because of new technology. It's not overutilization. And we need to take a really bold stand against this argument. Sure, we need to be very diligent in teaching people how to do things right and avoiding inappropriate care. We also need to get away from this argument that most venous disease is inappropriate care. It's just that argument is being made by people who want to keep us from being successful. And the third problem I'm going to talk about is the problem of physician burnout. And this is, I think, as everybody is aware, is a real significant problem. This is a great paper from Don Coleman looking at members of the SVS. And they actually had a reasonable response rate for a survey, 34% response, and used a validated burnout assessment tool. And about 40% of vascular surgeons had at least one symptom of burnout. And the really surprising thing to me in this is 8% had suicidal ideation within the last month. If you sit in a room of vascular surgeons, as I do all the time, 1 in 10 of the people in those rooms have considered suicide, which is astounding to me with that. Steve.
I don't know what is the suicide ideation for the general population.
I don't know. It's a good question.
You know, it's the same as that. It's not alarming. If it's 1%,
But a lot of people in the general population are unhappy. We think of vascular surgeons and doctors as being happy people. And
really?
Yeah.
Have you spoken to a arterial surgeon in the middle of an operation?
Yeah. That's why I said you're.
vascular surgeons in this room. I'm right now looking around, which one of you guys want to?
Yeah. Well, that was really astounding to me. And really part of this burnout problem suggests that the AVMS paradigm that we currently are following really poorly accommodates lifelong learning, new technology, and physician career changes over time. And you know, if we're going to fix the burnout problem of physicians in the United States, we need to change some of this AVMS paradigm.
Dr. Google says the suicidal ideation in the US is 4%.
4%.
In Canada,
Twice.
In Canada, it's 2.7 to 0.9.
We should all move to Canada, as I'm doing on September 1st. You know, and one of the, and Zoe's going to talk a little bit more about the paradigms, but one of the things that's being proposed, particularly by vascular surgery, is this focused practice designation, which is an experience-based pathway you acquire over time, which is a good idea. This is a good thing. The problem is the execution of this by the American Board of Surgery, because it's very siloed. It resides under an individual board. I'm not going to spend a lot of time on this, but just to compare the two, it's a more focused area of practice. Subspecialty requires fellowship training, while a focused practice designation is based only on clinical experience. For a focused practice designation, the practice may vary by individual, while subspecialty, every individual in that subspecialty has to look alike. And you look at this on the surface, and that seems like a pretty good idea. As I mentioned, the problem is really in the execution, is in that these remain siloed under individual boards. If Marlon wants to have a focused practice designation in venous disease and it's administered by the American Board of Vascular Surgery, he's not eligible for it. So it really does nothing to increase the pool of providers who are well trained to do this at all. So in conclusion, I think practice in the United States, as we demonstrated with the little exercise at the start, is guided by this outdated AVMS paradigm that doesn't account for the evolution of medical practice, doesn't allow for interdisciplinary care of patients, and it doesn't really meet the growing healthcare needs of the US population. And we desperately need a new model. And I would say, in contrast to anybody who said we don't need a subspecialty in venous disease, I would submit that we absolutely need it for all the reasons you're hearing today, for reimbursement, for the fact that we're grouped with all of these other groups, in determining our reimbursement. We don't have an independent choice. We need to control our own training. We can't rely on vascular surgery to teach us 1.4 sclerotherapy procedures and 0.1 venous malformations, or interventional radiologists to teach us a to be determined number of venous stents. We need to take control of our training to make sure we have an adequate workforce. And as I mentioned at the start, and Zoe's going to talk about more now, I think the AVMS recognizes this now. This is achievable. It may not be achievable in 1 year, 2 years, but just like the advocacy thing that we talked about earlier, we may not have been successful in getting everything we were advocating for in the last 5 years, but we have the infrastructure and we have the momentum and we have the membership behind us. And this is exactly like that. We do need this. It is achievable, but we have to start somewhere. So thanks very much. And with that, I'm going to turn it over to Zoe.